Okay, fantastic. Hi, everybody. It's Fiona Wolf again from Empire Justice. And this afternoon, we're going to be doing access to services in Medicaid managed care. I've noticed a typo there on our very first cover slide. It's obviously 2021. We're not caught in a loop of last year, thank goodness. So let's get started. We are clearly not tech savvy enough to add a poll in here, so we just wrote poll. But we did want to kind of put it out there. What's the most common issue that you as chat advocates experience for clients in Medicaid managed care plans? I know we don't have a poll where you can hit buttons, but maybe you could just pop something into the chat there. And then what we can do is maybe at the end, when we've got time for questions, we can have a little look and see what's sort of come up as the biggest issues people are facing. All right, let's take a look at the agenda for today. We're going to do an intro to mainstream managed care. We're going to look through the different types of managed care plans. We'll briefly touch on pharmacy. I know that we had a full training on it yesterday, so we won't dwell too heavily there. Some dental, care coordination, a few resources, working information on appealing denials and reductions. And again, like I said, we'll set you up with some references and resources towards the end as well. Okay, next slide. Right, mainstream managed care. So we spent a lot of time this morning just talking about Medicaid and the different ways people can access. So once somebody's approved for Medicaid, once they've been determined eligible, most people are going to be enrolling in a managed care plan. The plans available are going to vary by county, and the link there is to the New York State Department of Health, and it's the directory of managed care plans that you can search by county. Now, I'm saying most people are going to be accessing their Medicaid through a managed care plan. You don't have to enroll if you are exempt or excluded, but those who are exempt can enroll in managed care if they choose to. So who does that cover? Examples of people who can stay with regular fee-for-service Medicaid, who have that option. We're looking at populations who live in facilities for the developmentally disabled, some residents of long-term alcohol substance use facilities, Native Americans, and then adults in the Medicaid waiver programs, so maybe the NHTD, the TBI, OPWDD. And then some examples of people who must stay with regular Medicaid, who are excluded from managed care. Looking at populations of people who are maybe in hospice program at the time of enrollment, or living in a state psychiatric or residential treatment facility. Folk who get their Medicaid after a spend down. So those are your exempt excluded categories. But as I said, most people that we're working with are going to be enrolled in managed care plans. We've put a little visual on the page there, just so that you could see through that directory of managed care plans by county, which plans are available in Monroe County. It's where we're based, so just a little visual to see. You've got 6 managed care plans for Monroe County residents, and as I said, it will vary county by county. Okay, next slide. So how does managed care work? Well, Department of Health pays the insurance companies per member per month to cover the cost of care. So it's the plan, it's the healthcare plan that will pay for a person's care rather than fee-for-service Medicaid. If somebody's in fee-for-service, then the beneficiaries can go to any doctor or provider who takes Medicaid, and the provider bills Medicaid directly every time they provide a service to the Medicaid beneficiary. But in managed care plans, as I said, it's the plan that will pay for the care. Every plan has to cover Medicaid benefits at a minimum, and your Medicaid can be retroactive for up to 3 months as long as you're eligible in those 3 months prior to applying. It's going to pay for comprehensive medically necessary services. So we're looking at medicine, supplies, durable medical equipment, doctor's visits, hospital inpatient, outpatient, labs and x-rays, etc. So if somebody's enrolled in a managed care plan, they're going to see doctors and health providers that are in their plan's network, and they're going to have to follow the plan rules for accessing care. They'll be assigned a primary provider, and they must go to that provider in order to get a referral for any specialty care and for any prior authorizations that they might need for, say, non-emergency hospitalizations or other services. And just the sort of big takeaway, that the network providers are going to bill the plan directly and not New York State Medicaid like they do under fee-for-service. Okay, next page. So pharmacy benefit under mainstream managed care. New York State covers both medically necessary and over-the-counter drugs. And New York Medicaid has mandatory generic dispensing program. So prior authorization is required for any medication that is not generic. Now, if a person is dual eligible, so if they have Medicare and Medicaid, then Medicare Part D will replace Medicaid prescription coverage when a person has both. If a person is Medicare eligible and they're applying for Medicaid, they must take Medicare or they will be denied Medicaid. And a note at the bottom of the slide there, and I know this was sort of touched on during yesterday's training as well, that the carve out, the transition of the Medicaid pharmacy benefit has been delayed by 2 years until April 1st, 2023. So something that we will be dealing with in the future, but we don't have to deal with right now. How do I look up the managed care coverage codes? Well, you can go to the website that we've put on there, the eMedNey, and you can search through there for any specific codes, or you can call the client's Medicaid office at their local district, or if they reside in New York City, then you can call the Medicaid's eligibility line, and we've got the number set out on the slide there. But the best place to start is normally the eMedNey website that we put the link to. So now let's turn to some of the different types of managed care plans. There are a variety of different programs in Medicaid managed care. We've already looked at mainstream managed care in these earlier slides. So let's now go through managed long-term care plans, health homes, health and recovery plans, and the HIV special needs programs, or the HIV SNPs as they're known. So managed long-term care, what is it? Well, it's the delivery of long-term services, including home care or adult daycare, to people who are chronically ill or disabled and who wish to stay in their homes or communities. And these services are provided through managed long-term care plans that are approved by New York State DOH. Now, enrollment in a MLTC plan is mandatory for anyone who is dual eligible, so they're eligible for both Medicaid and Medicare, they're over 21, and they need community-based long-term care services for more than 120 days. Another sort of category of mandatory enrollment is for anyone who resides in the counties of New York City, Nassau, Suffolk, or Westchester. So it's quite a big pool of people who have mandatory enrollment in MLTC. Enrollment is voluntary for those who are dual eligible, so your Medicaid, Medicare, and are 18 to 21 years old and need community-based long-term care services for more than 120 days and are assessed as nursing home eligible. It's also voluntary for those who are non-dual eligible and over 18 years of age and are assessed as nursing home eligible. We've got a link there at the bottom of the page to the Managed Long-Term Care Plan directory. And if we were to click, I'm not going to click onto it because it's Alexia's screen, but if we were to click onto it and have a look at the plans, sticking with that Monroe County example, you would see that in Monroe County there are 8 partially capitated MLTC plans. There's one PACE plan, which is the Programme of All-Inclusive Care for the Elderly, and there's one Medicaid Advantage Plus plan. So again, the availability and the variety of MLTC plans is going to vary based on the county of residence. Next slide. So another type of care plan is a health home. So what is a health home? I always say this, it's not a place, it's not an actual home, but it's a group of healthcare and service providers working together to make sure that their enrollees get the care and services that they need. If somebody is HIV positive, they're going to automatically qualify for health home services. So the benefits of health home enrolment are these kind of add-ons, these extra benefits of care management services. So they're going to get care management, coordinated care management with their health providers, behavioural health and substance use disorder services. It's going to help people connect to the necessary medications that they might need, housing issues, extra assistance with applying or recertifying for social services, and really any other support services that are identified as being needed for the individual. Health homes are available in each county, and again, it's going to depend county to county how many health homes there are in serving the area where the person resides. And in order to be eligible for a health home, you need to meet one of the qualifying conditions. We've got a link there to the complete list of qualifying conditions. But to sort of summarise, you have to have 2 or more chronic qualifying conditions. Examples would include substance use disorder, asthma, diabetes. You'd have to have 2 or more of the chronic conditions, or 1 single qualifying chronic condition. And as I mentioned earlier on in the slide there, HIV positive would be a qualifying single chronic condition, as would serious mental illness or serious emotional disturbance. Okay, next slide. Oh, again, okay, so we're following through on that Monroe County example. You can see here, that was if you clicked into the which health homes are available in each county. You can see that in Monroe County, at the top of the slide there are 4 health homes that serve the area. 2 serve children only, 1 serves adults only, and then 1 serves both children and adults. So once a person is enrolled in a health home, they're going to be working very closely with their care manager. And care managers should be, verifying referrals for eligibility in Medicaid, helping their members renew Medicaid, and assisting those who may be eligible for retroactive Medicaid obtain the coverage and verify and maintain their eligibility for health home enrolment. Those who are over 21 and who may be eligible for health home services are identified through claims and encounter data. So what does that mean? Well, the state is going to provide a list of individuals just based on how they're accessing services. For example, multiple emergency room visits, no primary care. That's an example of how somebody might be identified. And the state's going to provide lists of those individuals to the health home for outreach and engagement. It doesn't necessarily mean that they're going to be eligible, but that's sort of getting the ball rolling. Then if they are found to be eligible, then they'll be assigned to a care manager. So that's for those who are over 21. For those who are under 21 and who may be eligible for health home services, the state has developed a specific tracking referral portal system in order to make sure that those under 21 are referred to health homes. There's also the possibility of community referrals. So really, a person can be referred for health home eligibility screening in a variety of ways. For example, a physician, emergency departments, if they see somebody coming through their door frequently, housing providers, shelters, even family members. So there's lots of options there to have somebody potentially channeled in to accessing those extra care coordination benefits. And our experience with clients enrolled in health homes has been quite mixed. Care coordination is key. I mean, that's really what it's all about. And there does seem to be Maybe some gaps sometimes in terms of expectations for clients in terms of how it will work going forward. At the outset, their plan of care is going to include goals. And once those goals are met, then at that point, the health home is probably going to look to, to disenroll a client once the designated goals have all been met. And that has, implications for clients. Now, just because a person is disenrolled because goals have been met doesn't mean that they can't be re-evaluated for future enrolment if things change. So just something to bear in mind. And if you are working with somebody who is, facing disenrollment from a health home, they should get a notice. They have to get a notice of disenrollment, and it has to state the reasons that they're being disenrolled. So just something to bear in mind. In the past, we have successfully helped a client appeal against, or a client's family rather, appeal against disenrollment for a health home in very unique situations. And we've also helped a client transition from one health home to another, just based on a breakdown of that care management, care coordination relationship. So if anything like that comes up, just a reminder that you can certainly refer things through the network for any guidance or assistance. Okay, next slide. Okay, so looking here at health homes and really care coordination organizations. For those with intellectual and developmental disabilities, they were transitioned into care coordination organizations / health homes back in 2018 as the first phase of OPWDD transitioning those populations into managed care. We're looking at person-centered integrated care model life plan. It's a great sentence. And again, it's that sort of combination of health and behavioural health services, community and social supports, and really any other services that a person's going to need in addition to those that they're receiving through OPWDD. And for those populations, there would be a team of providers and care managers. We've got a link there to show coverage by county for each of the care coordination organisations. Okay, the next sort of specialised plan that we will cover are health and recovery plans, or HARPs. HARPs are for those with significant behavioural needs or substance use disorder needs. And again, we're looking at integrating, physical care needs and mental health needs. This population transitioned from mainstream managed care back in 2016, and it transitioned into HARP integrated care. And they were identified based on utilisation of behavioural health or their functional impairment. And at that time, they were transitioned into a sister plan of the managed care plan that they were in, or they had the opportunity to opt out. So again, you're going to be identified as eligible for HARP based on usage of behavioural health services or by functional impairment. Must be Medicaid eligible. And individuals in HARP, they're going to work with the care manager to sort through which home and community-based services they will receive and what's going to benefit them. Again, it's a managed care product that's going to coordinate physical health and behavioural health, as well as non-Medicaid support and medications. And it really is, it's an integrated way for adults with significant or behavioural health needs to access all the services that they may need. HARP plans, they must be qualified by New York State and must have specialised expertise, tools and protocols that are not part of most medical plans. Okay, so it's just that added, that extra benefits for those with behavioural health needs.
Fiona?
Yes.
Hi, are you taking questions throughout the presentation, or do you want to take?
Yeah, we can, absolutely. Yeah, we're going to have plenty of time. I know this morning was quite rushed. We are going to have plenty of time at the end of this one for questions, but happy to take them as they come.
Okay, a question came in about managed long-term care. And the question was essentially, what is the process to enroll and how do you connect clients?
Oh, good question. I can. Managed long-term care enrollment is a process unto itself, right? That you have to, in the first instance, you have to be a person has to be assessed to be eligible for managed long-term care enrollment in the first instance, and then they have to go through the process of selecting a plan and finding out how many hours they may actually receive. So the ICANN network is the starting point really for anybody that you're working with who has questions about enrolling in MLTC and really helping to identify and solve any problems that a person might have in terms of getting their hours in the first instance.
Great, that's the only question.
And we can put a link in the chat there. We can put in the general ICANN contact information as well.
I'll do that. I don't know if everyone has access to the chat line, but I'll include that as well in the follow-up email.
But no, it's a great question because really, just getting enrolled in managed long-term care really is a big thing for anybody to navigate on their own. So we always encourage people to make sure that they're they're getting in contact with ICANN and that they really are exploring their options and making sure that before enrollment they fully understand the process and fully understand what happens once they are enrolled at a set number of hours.
Great. And someone also mentioned Medicaid choice to enroll. And I don't know if you have any information on that, Anna.
Just in terms of an option to help somebody choose the plan, yes.
Oh yeah.
Yeah, and I really think it is. I think a lot of it is just making sure that people, like I said, know what their options are and understand the process and understand that within limits, because depending on where you live, there might not be many MLTC plans in the serving the area where they reside, serving the county, but making sure that they're exploring the options so that they are getting the highest level of services that they can access. But if any more questions about MLTC, we're happy to take them at the end.
Thank you.
And that's just enrollment. Once you're in, then you've got to fight to keep your hours. So that's a whole other that's a whole other world. Okay, so turning to the final, specialized program here, the HIV SNPs, the HIV special need plans. These are specialized, it's a very specialized Medicaid managed care plan that's only available in New York City and is designed to meet the needs of those living with HIV or AIDS. I realise I'm missing a comma on that first bullet point there. Can be HIV negative, homeless or transgender. Just so that you don't have to be HIV positive. If you're HIV negative and you're homeless or you're transgender, then you can also access an HIV SNP. A person with dependent children can also enroll in an HIV SNP plan, and it's going to cover all Medicaid services and the benefits, those add-on services that they'll receive: an HIV specialist primary care physician, HIV care coordination and services, tailored information about HIV medications and side effects, treatment and adherence services, HIV prevention and risk reductions, and education for HIV negative members. So there's a lot of real benefits to HIV SNPs, and it really is a shame that they're only in New York City. For somebody who is eligible, they can choose during their Medicaid enrollment to be enrolled in just a managed care plan or an HIV SNP. Clients who are receiving their Medicaid through the marketplace, they can enroll in SNPs there. And clients with Medicaid through HRA, they can call Medicaid Choice to enroll in a SNP. Okay, next slide. Now we have a whole section on pharmacy benefits in Medicaid managed care, and I know that we had a whole training, as I said, on pharmacy. So I'm just going to go through these slides fairly quickly. It probably will be some repetition, but you know what? It's good to have this stuff sort of hammered home sometimes. Prescription drugs covered by New York State Medicaid for dual eligible members. There are only a few listed drugs that are covered by Medicaid for members who are also enrolled in Medicare Part D, and they're set out on this slide. New York State Medicaid will also cover certain over-the-counter drugs for dual members if coverage is not available under Medicare. And there's the eMedNey link to a list of the over-the-counter drugs that are covered. Next slide. How do I know if a drug is covered? Well, you're going to start by looking at your plan's formulary. Formulary is the list of drugs that are preferred by a plan, and they're usually only covering drugs, branded generic, that are on their preferred list. The formulary, the Medicaid managed care formulary, can change quarterly, and you can find a link on that page there to the model contract and a list of the managed care plans formularies. I would note at the very top of that website that we link to, the New York State MMC Pharmacy Benefit Information Center, there is a banner running across the top of that website just reiterating that the transition of the Medicaid pharmacy benefit has been delayed. It seems unlikely that clients will still be asking about the pharmacy transition now that we're in June, but you never know if there's going to be sort of any lingering questions about that. I know that we had some people who were approaching us when the transition was pending. I'm not sure how it was going to impact them, but I feel that that info has sort of filtered out by now. Okay, next slide. I've set out here just the Medicaid pharmacy co-payments. As I've mentioned, you know, there are payments due, and it depends on whether it's a non-preferred brand name, preferred brand name generic, over the counter, etc. And we talked about this morning actually, but a provider can't deny medications if a patient cannot pay. The provider has the right to ask you for the co-payment at each visit and to bill you for any unpaid co-payments, but they can't refuse to fill the prescription. Covered this morning as well, but you know, certain beneficiaries cannot be charged Medicaid co-pays, children under 21, the waiver participants, and then we have a $200 annual maximum out-of-pocket cost, and the year begins April 1st, runs through the end March 31st. So if you reach your maximum of $200, you'll be sent a letter that exempts you from paying Medicaid co-payments until April 1st rolls around again. And just a reminder that, you know, there's co-pays for other services, not just pharmacy. You know, you could be accruing co-pays for clinic visits, lab tests, hospital stays, emergency room for non-urgent services. So if your client has trouble filling a prescription, what do you do? Well, first of all, you need to find out whether your client is in managed care, and if so, which plan. Then you want to find out whether the drug is on the plan's formulary, and if so, whether any restrictions apply. Your client's provider, doctor, and pharmacist, really good source of information. And also you want to check the New York State Medicaid Managed Care Pharmacy Benefit Information Center. We've linked to this a few times in this presentation. It has all the information for the different plans and the plan contact info. There's a drug search feature that compares formularies across the plans. I've also got the number on there, the telephone number for the helpline. Next slide. And as I mentioned, each plan has its own formulary. So for anybody with chronic conditions where they have, you know, a lot of medications, named medications that it's imperative that they have, then they really do need to know ahead of time that their meds are on their plan's formulary. every plan's formulary must be comparable to fee-for-service Medicaid, and they have to have at least one drug available in each class. Again, the link there has all the info for the managed care plans, all the info on fee-for-service Medicaid, and DOH will update on a quarterly basis. Now, some types of drugs are not going to be covered under any plan's formulary. For example, drugs that are designated for cosmetic purposes only. But all health plans must have a process in place to review requests for those or any other non-covered drugs. Plans are able to set their own quantity limits. They can limit the number and the dosage frequency. And there is a standard prior authorization form for all plans. Just a reminder, prior authorization is when a drug needs exactly that. It needs prior authorization that the healthcare provider must seek approval before the drug can be covered. And the provider would need to be giving a rationale for covering that specific drug for their patient. And at this point, I'm just going to pause, and Alexia is going to take over, so you can listen to a different voice. I know I've been doing a lot of talking today, and I appreciate everybody.
Thank you, Fiona. I hope everyone can hear me okay. And I am going to drive this home. I appreciate everyone, staying with us. I know these trainings can be a bit, a lot, but anyway, just moving right along. So let's talk about changing plans. So first, for dual eligibles that get their drugs through Medicare Part D or their Medicare Advantage plan, they're allowed to switch plans once per calendar quarter, effective the first of the next month for the first 9 months of the year. I know that's kind of a mouthful, but basically after those 9 months, you're then locked into your plan until the next year. For everyone else, so for those not on Medicare, if necessary drugs are not covered by your current plan, but are covered by another, changing plans could be an option within the first 90 days after initial enrollment. After that, you are locked into your plan for the remaining 9 months. And after 12 months of enrollment in a plan, you can then switch. But it is important to remember to verify that if you are switching plans, that your client's doctor participates in the new plan. So prescriber prevails. Basically, the provider has the final say for the patient on whether certain medications are medically necessary for certain drug classes, even if not on the formulary. Even in the prescriber prevail drug classes, prescribers need to demonstrate reasonable professional judgment and supply plans with requested information or clinical documentation. So it's not just their word over the plans. They have to sort of prove that it's in their reasonable professional judgment that this is the better drug for their patient. And you can obtain mail order specialty drugs at any retail network pharmacy if the retail network pharmacy has agreed to a price that is comparable to the mail order specialty price. So potential issues. One issue is that your client's plan is not on the Medicaid Managed Care Pharmacy Benefit website. So you might want to ask yourself, is it a commercial plan? Is your client Medicare eligible? Another issue is that the drug might not be on the plan's formulary, or step therapy or quantity limits apply. Step therapy is when the health plan requires that one or more lower cost drug in the same drug class or in a proven clinical alternative drug class be tried first before they cover the requested drug, just because it's more expensive. So in the event that step therapy or quantity limits apply, or the drug is not in the plan's formulary, the client will need prior authorization using the standard PA form. There's also formulary exceptions, and another option is to change plans if you are eligible to one that covers the drug that your client needs. When denied access to a necessary drug, we just have some information here on appeals, and I know we talked about this yesterday, so I'll just quickly review here. All plans are required to have an internal and an external review process. So if the plan denies approval or discontinues a drug that had once been approved, the enrollee will receive an IAD, an initial adverse determination. First, you must request the internal plan appeal and exhaust that option. And you're likely going to get the final adverse determination unless they happen to change their mind. But more often than not, you're going to get a final adverse determination. Once you get the FAD, you have the right to request a fair hearing. Sometimes no FAD is provided in the required time limit. So if that happens, you can request a fair hearing without the FAD. And always remember aid to continue. If the drug was reduced or terminated, you can request continued access to the drug while awaiting the plan appeal and the fair hearing, only as long as you requested that within 10 days of the FAD or before the effective date of the FAD. Basically, in summary, the deadlines can be tight, the turnarounds can be tight, and it's really important to pay attention to notice dates and request aid to continue if that's possible. We are going to move on to dental networks now. So dental networks must be sufficient enough to cover the plan's service area. The network must include all of the following: oral surgeon, pediatric dentist, a TMD specialist, available oral maxillofacial prosthodontic specialist. I'm going to be using a lot of words that people may not have heard of before, but I can say that I believe maxillofacial has to do with your upper jaw. Also must include an endodontist, a periodontist in network, and someone serving those with special needs, such as HIV. EPSDT, which we've talked about a bit, the Early Periodic Screening, Diagnosis, and Treatment Program. Services for enrollees from birth until age 21 is also required. Under this program, children can receive periodic oral evaluations and preventive, restorative, and emergency dental care. The provider manual clarifies that this means that children should receive routine preventive dental care every 6 months and additional visits based on the dentist assessment of the child's individual needs. Basically, I do want to add, though, that under Medicaid, yes, dental benefits exist, especially for children, but the coverage is limited, as you will see in the next slide here. So dental and orthodontia care. Dental care, it includes preventive care, prophylactic, and other routine dental care services, supplies, and prosthetics required to alleviate a serious health condition, including one which affects employability. It also includes up to 4 annual fluoride treatments for children up to age 7. We get questions on this every now and then. At Empire Justice Center, we've seen some clients with questions about dental care, and sometimes, yes, the dental issues that someone is facing does affect their employability. But I just want to point out that the rule is sort of that if the prosthetics or the care or the services is only required to alleviate a serious health condition. Sometimes there's a health condition associated with a dental issue, but Medicaid doesn't cover it unless it's serious enough. And that makes dental appeals and dental service denials a little bit tricky sometimes. Just wanted to point that out. Also, some excluded dental services would be implants unless they're medically necessary and they require prior approval and supporting documentation. Other things like bridge work, unless it's for cleft palate stabilization. immediate full or partial dentures, root canal therapy for those 21 and over, except again, when medically necessary. Just some examples I just wanted to give you there. And as for orthodontia, for those up to 21 years of age for up to 3 years, active orthodontic care can be included, plus 1 year of retention care, but it's only to treat a severe physically handicapping malocclusion. So a malocclusion is an imperfect positioning of the teeth when the jaw is closed. I won't get into the specifics, but I do know there are specific rules as to how many points of contact there must be or not be in order for certain treatments to be covered, at least for adults, as you see. So it must be necessary, medically necessary, and it must be a serious handicap, according to the manual. We are going to move out of dental care for now and go into care coordination. So managed care plans must provide care coordination for enrollees with high needs, such as those with chronic illnesses, HIV, or physical or developmental disabilities, and those requiring long-term services and supports. All health plans have a member services department to help answer questions and resolve any problems with doctors or healthcare. Member services will help those health plan members needing special accommodations or extra support. Things like helping with healthcare appointments and forms, medical offices that are accessible or offer other accommodations, getting booklets or pamphlets in large print or audio format, case management services, things of that nature. And that would be under the member services unit. So now we'll talk quickly about parity laws. Parity refers to the laws and rules that dictate that mental health care must be covered in the same way as medical health care. New York has mental health and substance use disorder health insurance coverage parity. New York state and federal laws require most comprehensive health insurance plans to cover medically necessary mental health services and manage your mental health or substance use benefits as they manage medical and surgical benefits without additional limitations. And we listed out sort of the laws here that provide such parity. Plans cannot also require that you fail first at a lower level of care. So remember when we were talking about the pharmacy benefit, how there's something called step therapy. In the pharmacy benefit, they can require that you try a more generic drug or a cheaper drug first before they'll approve a brand name drug. They're allowed to do that in the pharmacy benefit, but it's not allowed in mental health and substance use disorder care. We also provided some links here for those who are interested in learning a little bit more about the parity laws. So in New York State, Medicaid managed care plans must use the following medical necessity criteria when assessing for mental health services. They must be evidence-based, peer-reviewed, they must be age-appropriate, and they must be approved by the Office of Mental Health. If a service is denied, the denial notice must include all of the following: the specific reason for the denial, the relevant code, the meaning of the denial code, and a description of the standards used in denying the claim with a reference to the specific plan provisions that were relied upon. Basically, they're trying to make sure that the managed care plans don't just get away with denying services under mental health by just glossing over things, by just saying, oh no, you don't need that. They want to make sure that there are specific reasons in the same way that there's specific reasons they can deny medical healthcare services. That's the parity. Okay, so I know we have in the past, or at least CHA has done in the past, full trainings on appealing denials and reductions, on fair hearings, on external appeals. So I know we could do a whole training on this, but just in the interest of simplification, we put it all on one slide here. The process for appealing denials and reductions in mainstream managed care is first the internal appeal. So first you would receive the IAD, the initial adverse determination with the denial, with the reason for the denial or the reduction. And first you must submit the internal appeal with the plan. Only after you get the FAD may you request a fair hearing, unless of course they failed to provide the FAD in the proper time frame, in which case you can request the fair hearing due to deemed exhaustion. But I do want to point out something really, really important. We tend to request our fair hearings online so that we can have a record of what exactly was requested from the OTDA website. And there's nothing in the system that's going to prevent you from requesting a fair hearing improperly. So basically what I'm saying is, let's say you request the fair hearing without the internal appeal first. Nothing in that system is going to really stop you from moving forward with that. So it could happen that eventually you get the fair hearing confirmation, it's then scheduled, you go to the fair hearing, you're talking to the judge asks you questions and says, wait, there's been no internal appeal. Well, I can't rule on, I can't hear the substance of this case. You were supposed to do that first. You were supposed to file the internal appeal first, which is really frustrating because of course now you've wasted a ton of time and you're outside of you could be outside of some deadlines. So I just want to point that out because it can be tricky, especially when folks come to us after the fact. Maybe they requested their own fair hearing and they didn't know that they needed to do this internal appeal first. So you hope that people come to you soon enough, but I just want to point that out. Sometimes it does happen. Anyway, though, moving on, you also have the option for the external appeal. Once you get the FAD, you can also request an external appeal, which is instead of being reviewed by the Office of Administrative Hearings, like a fair hearing is, this is reviewed by the Department of Financial Services, usually a medical doctor they contract with that reviews the individual appeal. And you're welcome to do both at the same time. You can request a fair hearing and you can request an external appeal and you can follow both paths. But because the fair hearing decision always trumps the external appeal, let's say due to timing or whatever, you happen to get your external appeal decision first. If it's unfavorable, then great. You still have your fair hearing option available to you. You keep going, you keep trying. But if your external appeal decision comes back and it's favorable, you might want to consider withdrawing your fair hearing request because it still applies to the plan. But if you happen to get a fair hearing decision later that is not favorable, then it trumps the external appeal decision. Also keep in mind in the first 90 days of enrollment or past the first 12 months of enrollment, you always have the option of switching plans in order to improve access to things like medications. And I guess I'll just also add before I move on real quickly, if anyone's got fair hearings coming up or is thinking of requesting a fair hearing or an external appeal, please feel free to reach out to us. We're happy to help you prepare. We're happy to guide you through the process if it's, if you're nervous about it. And that's how we prepare. We usually practice our arguments on one another, even at Empire Justice Center. So if anyone has any questions about this, about preparing for a fair hearing or for an external appeal, we're also available for that as well. A couple specifics about Medicaid during the COVID-19 public health emergency, which this should be mostly review for you all, but of course, everyone with Medicaid coverage on or after March 18, 2020 keeps the coverage unless they voluntarily cancel it or move out of New York State. Stimulus checks are not countable income, but they are exempt resource for after 12 months, or for 12 months, and then they become a resource. Sorry about that. We also have some information on coverage through your local district and spend down rules. If you've got specific questions about coverage or spend down questions, if you're outside New York City, definitely feel free to reach out to us. If you're inside New York City, definitely feel free. I'm sure you can reach out to CSS and Legal Aid Society. And we listed here just some references we use throughout the training on managed care plans, the model contract, health homes. We also provided some resources here, including the Office of Managed Care complaint line and an email address for submitting complaints to the managed care complaint line. Information about Medicare Rights Center, the MLTC complaint line, New York Medicaid Choice, and the pharmacy benefit, the prior auth form, eMedNy, and some other resources, including immigrant eligibility for Medicaid. And lastly, just our contact information. So I will open it up to questions. Looks like we have some time for any questions, but also feel free to reach out to us, offline after the training. We're also available. So
Thank you so much, Alexia and Fiona. I'm taking a look to see if there's any questions. Again, feel free to type in any questions into the questions tab. But so far, there are none.
okay.
Yeah, this was a very helpful training. Thank you so much.
Yeah, of course. And if we, once we log off or whatever, if we've moved on to another training tomorrow and all of a sudden a question arises, then definitely feel free to reach out to us via email. Sometimes it takes a little bit just to digest all the information, I know, so.
Right, exactly. So yes, feel free to reach out directly to Fiona and Alexia or at health@empirejustice.org. Also, you can send me questions and I can forward it to them. But since there are no other questions, we can conclude today's training day. And tomorrow we will begin at 10 a.m. with Medicare Part 1. So thank you, everyone. And thank you again, Fiona and Alexia. Have a great